Welcome to our second webinar in our series. Today's webinar is titled Click the Link, Digital Approaches to Accessing Health. And today is an extremely important topic of discussion, especially in a time whereby we need to stay at home, we need to stay away from each other, but at the same time still need to access very important services. In fact, now is a very important time for us to access health services. And while being asked to stay away from other people, it makes that extremely difficult. So to help us think through some of these obstacles, the opportunities available to us, we have a wonderful panel whom I will introduce shortly. And I think today is really an opportunity for us to also get a little bit of a snapshot into what the future of health and health services could look like. So with no further ado, I'd like to introduce our panelists in no particular order. We have the wonderful Nomtika Mjwana, who is a communications and digital health project manager with notable contributions in sexual and reproductive justice and HIV field working areas. She currently manages digital health projects for the global network of people living with HIV, which includes being a member of the Digital Health Rights Group, advocating for human rights-centered digital health policies. We have Nana Abelsu, who is a feminist researcher on sexual and reproductive rights at the Egyptian Initiative for Personal Rights. She is a member of Realizing Sexual and Reproductive Justice Alliance, a sexual and reproductive health coach at the Geneva Foundation for Medical Research and Education, and a fellow of the Transformative Research Arab Families Working Group. And we also have Dr. Ifani Nsifo, who is a leading voice in global health equity, health security, universal health coverage, digital health, and health research. He provides strategic leadership for EPI-Afrique Health Meets Tech Hackathons. He has worked in government, international non-profit organizations, indigenous non-profit health organizations, and the private health sector. He has worked on launches of two successful health startups, namely Nigeria Health Watch and EPI-Afrique. He is also a senior New Voices Fellow at the Aspen Institute and Senior Atlantic Fellow for Health Equity at George Washington University. So welcome very much to our panel, and thank you for joining us today to join in on this very important conversation, where we cannot wait to hear your insights and also share in the glory of your expertise. So in preparing for this webinar, I thought it's so interesting that we have three panelists who work, yes, in health and in also like digital health, but in three different contexts on the African continent. And I think it's an important kind of bringing together of different perspectives, especially in the context of Africa, and also very significant places in Africa, because often I think one of our biggest downfalls is the lack of communication and synergy. And in many of our systems, the opportunity for that kind of communication is often not available. So I'd like for us to start with a sort of, a grounding question and introduction that all three of you can contribute to. So doing work in three different African contexts, which have a great influence on the continent, I'd like to hear from each of you what accessing health looks like for the average person where you are. I think let's start with Nomtika.
I'm just going to be thrown right in the spot.
It's all love, all love.
Thank you, Jamal. So the question is, how does accessing health or digital health specifically look like in my context? So I think I will just start off by saying that it's a complex question because the response depends on who you are. It depends on where you are. It depends on what resources and infrastructure is surrounding you, if any. And it also depends on a lot of various aspects like, the political will and who is basically responsible for ensuring that there's equitable access where you are. And so, for the average person, there isn't necessarily a uniquely distinct answer in terms of accessing health in general. I am in South Africa. We are in Africa. We're in a country that's generally stratified in terms of resources, particularly when it comes to healthcare. And so, when you think about digital health more specifically in the continent, and at least in the work that we've been doing in Ghana and looking at Kenya, with the DRAG project, which is the Digital Health Rights Project, we've also noticed that even the different ways in which digital health interventions are being implemented in the continent is quite different and depends on various aspects. For example, Ghana isn't necessarily an extremely advanced country digitally when it comes to accessing digital resources in general. So digital health is much more based on telephones and SMS. Whereas in Kenya, there's a couple of emerging digital health technologies, but then again, access as well depends on who and where you are. And if you look at South Africa, it's much worse because we have cities that are high performing, that have a high internet and digital penetration in general, but we also have provinces and regions in the country that are also still very rural, and those particular contexts definitely affect how people access health from a digital perspective. So it's a really broad question, but I think it really depends on where the individual is, what infrastructure and resources you have access to. And for digital health, it's still a very long way to go in the continent in general, and I think with respect to each unique country and region in the continent.
Yeah, so definitely an important theme coming through is that contexts are stratified and the access to resources are stratified, and that's an important consideration to make when approaching this topic. Nana, how about the context that you operate in? What does it look like over there?
Thank you. Well, I think it will be really essential to think of all the structural barriers that are present in the overbearing in real life and on the street, and take it and apply it to the internet. I think like with minor differences in how the internet makes it or digitalizing health services makes it convenient for some, it is still inaccessible for a lot of other people. So like speaking in the Egyptian context, for example, if we take a look at how it was very convenient to sign up for vaccination for COVID, and like to sign up for the vaccine, it was initially introduced as a commodity that you can access by signing up online. This does not take into account the digital illiteracy. So it doesn't necessarily mean that when people the number of smartphone users, for example, or the number of people connected to the internet doesn't necessarily translate into digital literacy. So taking this into account, it was only convenient as a sign up process or step for a specific group of people who actually can even double check which vaccine they would, depending on the situation and the context, like which vaccine to go for. The ones that can assess and make a judgment and make a choice based on that are the ones who have access to a foreign language, the ones who speak English, for example. So now we have the access to the internet as a commodity. You pay to actually be online, and then making up your mind on which way to go is these are all familiar determinants, health determinants that we have offline, but somehow in digitalizing the access to health did not get really interpreted as like obstacles to accessing those services. So I mean, like for an average person, the internet can be arguably thought of as, or digitalizing a service, the health services can be thought of as something that made it much easier for people to be to access information, to book services, to have knowledge in general and awareness, and increase their awareness regarding any health issue. But it can also be thought of as something that is making it more inaccessible for others who don't have the same access. And I'm speaking of class, I'm speaking of individuals with and their in respect to their immigrant status, people who don't have identity paper, people and also speaking of gender in rural areas, how is this also playing out, and also trans needs, health needs, of like how you may access the internet to get information, but the services are not translated on the ground. Like you cannot access services on the ground. So like you would have information about health services, but you wouldn't necessarily be able to access the service itself. So like there is a widening gap between how much knowledge you can attain regarding any health issue online, depending on many factors, but that doesn't necessarily guarantee you an access to those services in general. So this is just like really briefly.
Yeah, these are interesting, and so far, I mean, we've only heard from two of our panelists, but what's coming through really strongly is that the infrastructure and the general sort of systemic support for such an intervention is currently quite disjointed, and that all the pieces of the puzzle are not even available or well put together yet. So, Ifeanyi, if I can ask you, then what does the picture look like in your context?
All right, thank you so much, Jamil, for having me. Great to hear from Nana and Nomtika. So Nigeria, we're about 200 million people, and if you look at our total health expenditure, the last time it was estimated in 2018, it was about $10 billion per year, total health expenditure. Now, about 77% of that's $7.7 billion, are out-of-pocket expenditure. People pay when they access care, health insurance. Now, $2.3 billion out of that, people spend in community pharmacies. And that is where the majority of Nigerians buy their health care. When people are sick, their first port of call is to go to a community pharmacy to meet somebody who is not properly trained most of the time. These are business people who run small shops where they sell drugs to access care. And even our firm in 2016, we did a survey, nationwide survey, to look at health seeking behaviors and referral patterns. And that, we found something similar. Because one of the questions we asked people was, so in this community, if you fall sick, where do you go to first? Overwhelmingly across the country, people went to chemists. And that's a major problem for us, because if you look at Nigeria as a nation, less than 5% of the country has any form of health insurance. And yet, $7.7 billion, spent out of pocket. If you compare that amount to what international donors bring to the country for healthcare, international donors only bring $1.1 billion. So what Nigerians spend on healthcare is 7 times what international donors give us. So which tells you that as a people, we should not be concerned with international donors, but focusing internally to make sure that at least we channel that high out-of-pocket expenditure towards health insurance, which is something I've spoken about and written about, several times. And if you now bring it to digital health or access to healthcare through using digital health, although internet penetration is quite high in Nigeria, virtually everybody owns a mobile phone now in the country. If you look at social media, about 40 million Nigerians are on Twitter, another 34 million on Facebook. So people are present there. However, I think more people actually use WhatsApp, for instance, for asking questions, for disseminating all sorts of information, whether they are false or they are true. So there are opportunities there for accessing for using digital technology to at least improve health equity for our people. But for me, most importantly, we need to think as a people on how to channel that high out-of-pocket expenditure for health insurance so that people can get better quality healthcare wherever it is that they are based in Nigeria.
Definitely, and also I think and this is what I hope that spaces like this do, is to create that sort of intra-national and sort of transcontinental dialogues that allow people into different contexts to see, oh, that works there, that doesn't work here. Perhaps we can adapt this thing to try it here, kind of thing. And I think that is really how this kind of model eventually perfects itself, or we would hope so. So I want to come back to you, Nana. So your work takes an interest in the structural and systemic barriers to accessing information and knowledge, also in relation to sexual and reproductive health. So, and you touched on this in your initial response, but what, in terms of the work, and I know you also do research, right? So in terms of the research that you have done, what are some of those barriers that people face in Egypt? But then also, is there any indication of how people have tried to overcome it?
I accidentally touched upon this in the introduction. I get super excited about structural barriers, obviously, but speaking of like how people try to overcome this and what are the structural barriers there. So like for research, for example, there are no data sets, updated data sets that we can rely on to actually make policy recommendations, to offer solutions, to bring in alternatives. So the latest data set that we have in the Demographic Health Survey, for example, dates back to 2014. And the one of 2018 got canceled with no proper official communication of why this would not run and what were the alternatives for like the gap years from 2014 till 2021. For example, if I want to speak to or address any health issues that were listed in that survey, for instance, like reproductive attitudes, reproductive choices, female genital mutilation, and all of the, domestic dynamics that can make us read through the barriers and offer solutions. So like the first big obstacle is that any major national program or campaign is not based on evidence. It's just convenience. It's what sounds convenient for this point in time to be carried out, is like, random things, like things that you cannot even compare and see like, okay, well, based on the data from X year compared to Y year, then we have like those changes. No, we don't have access to that. So this is really the major obstacle. The second obstacle again is class. So class, it's interesting because this is the second day in a row that I'm speaking about class and people are calling me Marxist for doing this, but it's just something in class because like it's a huge obstacle that for some reason poverty is not something cool to talk about anymore. Something is not, it's becoming very interesting how we're shifting away from this and being very accomplice in how we even view things. So class, like right now, it's interesting to watch a lot of online platforms run by feminists on Instagram and Facebook, talking about a lot of sexual reproductive health issues. And for the first time, it feels as if like we have feminists grabbing the mic from doctors talking about, bodily issues in general and like spreading information and so on. But this is again something that is only accessible for users who have their algorithms landing them in those platforms, right? So like it's and we know the algorithms are not fair, they're not just, and they're not nice in general. So like we have so we have this, like these are platforms that are only accessible for people who have access to devices and internet. We can pay for internet to actually watch and follow, and they also have enough knowledge to know that this is something to to be able to use it and utilize it. They need the bare minimum of knowledge background and educational background to be able to actually go there and use that. So we have this, and on the other hand, we have all national campaigns that aim to raise awareness on specifically sexual and reproductive health issues. And I mean, the national interest only goes to reproductive health, nothing really to cover sexual health. It's very traditional and it's very outdated. And it's like about having, some community leader knocking on someone's door, telling them what they should and should not do with their bodies, because this, for some reason, at some policy making meeting, that sounded like a good idea to bring in, for example, fertility rate now. It's like, oh, go tell this woman it's okay to have just 2 kids. That's enough. I mean, like, so have we tried to ask this woman like what she really needs, and what are the challenges that she faces in actually spacing children, having more children, having less children, so on. So this top-down dictation of what should be done, that is based on no evidence, that is based on no participation or wider conversation, is quite concerning, of like undermining and violating a lot of other human rights in making this, while capitalizing both nationally and internationally the amount of work and resources put into digitalization, for example. So digitalization sounds as if we've, advanced our ways of life, but in reality, it's not really reflected on like how people are able to pursue healthy lives and that is attentive to their well-being and making people the center of those decisions. The other ways that people have been trying to overcome this on a community level is, WhatsApp, and but again, like information being circulated on WhatsApp. We've seen this especially in Corona, like with Corona, is like having community initiatives where people would deliver food, home cooked food, to people who were diagnosed or were showing COVID symptoms. It's like we would have like community initiatives, but again, all of this is just only happening online or through digital medium. So again, it would make us think of like all the other people who don't have access to internet and who don't know that these things exist. So digital literacy is one huge obstacle. Data and lack of data is another huge obstacle. And again, and amid of this, it's really interesting and refreshing to see feminists, debunking the whole medical myth and medicalization of bodies and taking over the platforms for this. But again, what is persistent is the structural barrier of poverty and class. And I think I'll stop here and I'll develop later.
Yeah, I can definitely, I resonate in terms of my own thinking around this issue with what you have been speaking about, especially in the South African context, because like Nomtika mentioned earlier, we have such a stratified society, where, the people live in extremes, on the one end, it's people having an access to a world within worlds, at the touch of a button or at their fingertips, literally. And then there are other people who don't even have smartphones that have become something that's almost like it's not spectacular anymore. Like a smartphone is almost like it's the most ordinary thing in the world. And yet, here in this very country, there are people who don't have access to it. And there's something that you mentioned about, the top-down approach and people being told what to do with their bodies. That brings up a very important aspect, which is that of human rights. And you also spoke about algorithms, and we know for a fact that these algorithms are racist, they are classist, they are ableist, and it matters, it absolutely matters who is creating the algorithm and what their frame of reference is. So this segues really nicely into the conversation that I'd like to have with Ntika, because so in the sector, your work brings in a very important aspect of human rights. And besides, what we've sort of introduced with this, what would you say are the kinds of things that we need to consider about human rights when we use digital technologies for accessing health?
Sure. So I think this question actually is one of the reasons why I got drawn into thinking a bit more around what digital health looks like from a rights perspective in general. And I think just a general reflection to start us off is that over the last decade or so, I mean, we've seen digital health emerge, right? But there's been a bit of a shift in terms of what digital health was primarily introduced, or at least initially introduced for, and how that has shifted over time. In the last couple of years, digital health had been mainly about, broadening access, as Nana would say. And we've seen how that works, how that doesn't work, how having, referral points and maps on where people can access abortion services, only to find that those are dated sometimes because there's not enough verification, which violates people's human rights because someone spends their last bit of money to go and try and have an abortion, which is one of the greatest solutions that people who opt for that could have, and you realize that the facility that you've gone to is closed. And so there's been things that worked and that didn't work around just the initial idea of what digital health was supposed to be for increasing access to information, increasing access to services, and over time, and also obviously because of COVID, it shifted into being more of a necessity, right? To limit the crowding of facilities, to and also with the concept of self-care, where we're empowering recipients of care to take charge of their own health in as much as possible, in as many ways as possible, self-administered abortions, HIV self-tests, and most of those things are accompanied by digital health. And then it's just health is just becoming part of the digital revolution, right? Which is a lot of systems are being digitized, but there's so much just that's looked at in terms of what those interventions are, and less about the human rights centeredness of those interventions. And I mean, just thinking about digital health more broadly, one of the things we've been grappling with is defining what it looks like, right? There's e-health, there's m-health, there's all kinds of definitions. And more than people accessing a particular, USSD, number-based service or a cell number or an SMS line or a app, people also access, digital health on social media, as Nana has mentioned. So I will inbox the doctor and ask them about a question, and I get a response without them necessarily diagnosing me to the fullest what we may consider to be the most accurate manner. And that's also quite subjective. There's telemedicine as well, but also people just like taking pictures of themselves. I mean, one of the consultations we had recently were people saying, well, we don't have any apps, we don't have anything. I just take a picture of whatever boil I have under my breast and I send it to my doctor and they will tell me what I need to do. So there's so much information and data and a lot about ourselves and about people that goes out into different platforms that isn't necessarily regulated in terms of who gets access to that information, where is that information stored, where does that information go, and what rights do I have about that data of mine once I've already given it to you. And when Nana speaks about digital literacy and just that spectrum, the spectrum of digital literacy alone, it's very broad, because also when we go to certain people and communities and we talk about, their right to privacy, their thinking is, well, if I've got a password on my phone, that's enough. right? And so it's about thinking about how can we be human rights centered, not only from thinking about issues of privacy, but also thinking about who is that end user, who is that health worker that's going to be using and receiving this information, as well as the person that is the either recipient of care or patient, or whatever terms that we want to use. So the first core aspect of it is that. So the issue of privacy and human rights centeredness. And on the issue of privacy, we work with communities who are often marginalized. We work with queer communities, we work with sex workers, we work with people who use drugs. And some, countries and contexts that also have digital health services also criminalize these communities. So there's also big questions around what happens to me if I enter my profile because I need a health service that is tailored to me. What happens when I enter my information and on a platform that sits in a country that already criminalizes me and my rights? So it's really thinking much more in depth about the persona that is accessing these tools and what it means for them and their context as a whole in general. And then the other aspect then I think is what Nana was talking about in terms of the algorithms and AI technologies being classist, being racist. I think you alluded to this as well. And also just voice commands alone being very selective of which accents make sense to be able to pick up and respond to. So it's really the aspect of inclusivity and thinking about what does an intersectional framework look like in digital health, because we have to think about digital health. So we have to think about access to health. So that's where issues of infrastructure and access and making sure that there's resources for people to be able to access these interventions we put on these digital platforms. But there's also the core aspect of digital rights, which actually implicates him. I mean, I'm sure all of us are super tired of seeing all these poor PA message emails on our inboxes, because everybody has to make sure that they tell us that we want them to keep us in their inbox, or we want to keep them in our inboxes. But that's just a very small aspect of it. And actually, how many people really open up those emails, even if it's for organizations and companies, they don't want to hear from them anymore. So I think there's a lot of work generally to be done in strengthening digital rights and just adding the layer of digital health, of health in general, as a basic human right, then really makes it a more complex issue and a more complex dynamic that we need to think about. But I would just highlight that it's issues of privacy, access, and the human rights centered approaches to thinking about who the personas of those platforms and these different tools that we use are.
And I think, for me, that links nicely into a previous point that Ifeanyi made, that was thinking about, especially in the African context, because of the fact, and yes, we know why, because we are entangled in colonial agreements that keep us dependent on the West, but thinking about ways in which to generate resources so that we can tailor solutions by us, for us. Because when we talk about algorithms being created and generated, often the people doing this are sitting in other parts of the world with a particular frame of reference for what the human looks like and what the human is entitled to, right? But even that is a subjective idea. What is a human, right? And then the other important point you made, I saw the other two panelists looking a bit like deadpan when you mentioned the poppy A things. So recently in South Africa, we've had this legislation that's been passed around the protection of personal information. And so as a result of that, a lot of organizations that, these newsletters and things that you sign up to, they had to reach out to everybody to ask them to please reaffirm their permission or revoke their permission for being contacted. But the point, interestingly, that came through there was the fatigue to actually read these things and check what is being said here, what am I being asked, because it's often quite an overload of what seems to be inconsequential information. But this actually comes down to an important point, and that's the idea of community, right? And so with your work, Ifeanyi, it does many important things, but one of that is health communication. And that is something that we desperately need, especially in this time. I think it's been shown not only in our country, but over the world, that a big failure of the global pandemic response has been ineffective health communication. It's not that people can't understand what the issues are. It's not that they can't receive the urgency around the health interventions that need to happen. It's that it's not being communicated to them properly. It's not being communicated to them in ways that they can access, whether that be through the language that they speak, or, a myriad of other factors. So would you mind if I need to give us like some pillars around what good health communication should comprise of? You're on mute.
I knew this was going to happen. Thank you so much, Jamil, and great, insights from Nomtika and Nana on human rights. And so, it's just interesting that I think that sometimes for us health workers and people who work within the development space, we kind of talk to ourselves. We think we're talking to the communities that we're serving, but we're really just conversing and talking to ourselves. And that's why for me, I think in communication, I think first of all, we need to understand who is it we're communicating with. So if we look at the different stakeholders, different strates of society. So in essence, if the way I would communicate with Nomtika, for instance, is not the way I would communicate with my aunt in the village, or a car mechanic by the roadside in Abuja here, because, they have different characteristics that I need to take into consideration. And obviously, it's also how do we craft the messaging, and what mediums of communication are we using? Because we may be so bogged down by the fact that, internet penetration is high, people are on social media, but then how many people, even if you're talking about equity and access, how many people have money to buy data? Data is quite expensive in Nigeria, for instance. So if you're concentrating on that medium, digital medium, then you're really excluding lots of people. So I think bearing that in mind, and a country like Nigeria, if you look at Nigeria is a very interesting place, apart from the huge population. If you're going from northern Nigeria, from say, Kano State to Lagos State, you're going to pass through the savannah, the Sahel, all sorts of geographies for you to get to these places. And doing work in the health space, if you want to communicate, say, to people in northern Nigeria, a very good way, an easy way of doing that is through the radio, because virtually every man there has a radio that they listen to, and they are very, very clinical about listening to their radio. So I think the channels of communications are really, really very important. But from the work that I do in health advocacy and the training that I do for people and different organizations, I've also tried to unpack communication, communicating with people using a formula that has three different aspects. So first of all, what is the problem? Because if you look at social media, for instance, a lot of people think they are communicating, but they are ranting. Nothing is working in this country. This, that, we don't have that. Okay, we know that's the problem. So being able to define the problem, I think it's very, very key. Now, if you define the problem, then what are the solutions? Because like I said initially, you may think that people know the solutions, but they don't know because they are not in your space. So being able to articulate the solution, to solve the particular problem that you've identified, I think is very important. But to me, most importantly, the third aspect of this formula is, what are the calls to action? What do you want me to do? That demographic that I belong to. So let's use, say, the vaccine hesitancy, COVID-19 vaccine hesitancy in Nigeria. We've identified as a problem. People are not taking it. What are the solutions? We want people to go and take it. What are the calls to action? So if I'm speaking to, say, a religious leader in Nigeria, because I know that the bulk of vaccine hesitancy in Nigeria is driven by religion. People listen to their pastors, and because of that, they don't want to take the vaccines. There needs to be very clear on what it is I want that pastor to do. Because On the other hand, if I was speaking to a town, a community leader in the village, for instance, what I want that person to do would differ from what the religious leader would do, would differ from what the government official would do, would differ from, what advocates like Nomtika and Nana would do. So I think for me, I've seen this really work out in the work that I do, defining the problem, identifying the solutions, but crafting the calls to action for different groups of people so that at the end of the day, because when we're communicating, we don't just want for people to know, but we want for people to take action to change behavior. Because if ultimately behavior doesn't happen, I think that you have not communicated. You may have to go back again to revisit what you've said, how you said it, who to engage to say it for you, and it's just so important. And I think in all the discussions around health equity, COVID vaccine inequity, all the things you're talking about, to me, the most important thing is that it's either people have not heard or they've heard, but they don't understand what you're talking about. They understand, but they don't really know what to do in order to achieve what it is you're asking them to do until they take that action to change behavior. And using the instance of COVID-19 vaccine, actually going to take the vaccine, we will not say that we have communicated. It's just so important that sometimes we begin to wonder, why are we not a bit more proactive about making sure that our communication is very, very strong before we even start, rolling out different interventions. Thank you.
Yeah, it does seem often that, people responsible for rolling out such communications, it's as if the job ends at rolling the communication out, whether it's of a good quality or bad quality, whether it's been heard, whether it's been internalized, doesn't seem to be much of a concern. And I mean, it's almost just like, throwing a bunch of words at people and hoping it lands somewhere. Yeah, it is a big problem. And it's a part of the like I mentioned earlier, that disjointed system that doesn't take all the puzzle pieces into consideration, or necessarily even knows how to put those pieces together. These have been some really, really, really enlightening insights, very, very important contributions for this discussion. And also gauging from what we've said so far, this is definitely a field, an important field, but one that's quite in its infancy. It's something that needs a lot of work. It needs more time, more resources, and of course a lot more sort of discussions that allow in differing perspectives. Because if I had 3 other people sitting in front of me from different contexts, the conversation would be completely different, because the things that people need to consider in other places are not the same. But with that said, I was thinking about, of course, an important place always to go with these discussions is that vision for what it could look like. And I'm also happy that all 3 of our panelists have such strong orientations towards justice-centered solutions, within this field. So I'd like to hear from each of you. What do you think, going forward? Because this is an opportunity, as much as there are obstacles, it's an opportunity for us to imagine something new. So when you sit and think about the work that you are doing, what do you imagine this should end up looking like, or could end up looking like, in terms of effective, equitable healthcare? Let's take Ifeanyi. Let's take you.
All right, thank you so much, Jamil. So for me, so I have 2 daughters. I have 2 kids, and they are both daughters. My first daughter is going to be 12 next month. Her name is Yagaze. My second daughter, she's going to be 9 in November. Her name is Chimamanda. Everybody knows Chimamanda because of Chimamanda Adichie. And my first daughter was born in 2009. 6 weeks after her birth, we found out that she was born with congenital heart defects. And you can imagine what that meant for my wife and I. Young couple, just got married a year after, have a kid, congenital heart defects. In Nigeria, where we didn't have the capacity then to do open heart surgery. And what that meant was that we had to go through all sorts of rigor, eventually taking our daughter to India for an open heart surgery, where it was corrected. And anytime to me, that was an eye-opening experience to health inequity. And the fact that, before then, when I talked about having access to healthcare, how health expenditure can push people into poverty, I was just saying it because, well, that was what I was supposed to say. But I had a first-hand experience. Because even for my wife and I to be able to pay for our daughter's open heart surgery in India, we had to take loans from our employers. I got a loan from my employer. My wife got a loan from my employer. So literally, to pay for our daughter's open heart surgery, we went into poverty because it took us like 3 years to pay back our loans. And for me, what I've really been advocating for since then in Nigeria, across Africa, is that people need access to healthcare and not paying for healthcare when that need arises. And that's why, for me, it is mind-boggling that the total health expenditure in Nigeria is so skewed, for that very high out-of-pocket expenditure. And we're bogged down chasing donors when we have all the funds within to actually reorganize our system so that people can pay for health insurance. So what I just want to see is, people having access to healthcare, no matter the country where they are based, across the continent. We can have, situations where women die because, they are in labor. There is no functional health facility where they are based, or they have to travel long distances, before they get healthcare. And we just keep talking about it over and over again. And in Nigeria, it's so ridiculous. Almost 60,000 women die every year in Nigeria because they want to give birth. Do you know the population of Seychelles country? Seychelles is like 100,000 people. So what you're saying is that like 60% of the population of Seychelles dies every year. If you compare it to women who die in Nigeria because they want to give birth. So that's really that to me is the future I want to see, because ultimately for me, and I've given a TED talk on this, that without health, we don't have anything, to be honest. COVID-19 has shown that without health, we don't have anything. Everybody's, we're all at a standstill trying to resolve this particular health issue. Thank you.
Also, I wanted to remind you, you want to give us a quick insight into the Epic Africa hackathon.
Okay, so briefly, in 2017, we got a small grant from Facebook to organize hackathons across Africa. And before then, we had a conference where we got the Facebook partnership manager for Africa and the Middle East then, who spoke at our Health Meets Tech Future of Health conference. And we got that grant from them. From 2017, we had our first hackathon. The whole idea of the Health Meets Tech hackathon is getting the health and tech groups together to form this ecosystem that will begin to develop tech solutions for health issues across Africa. And, so hence the name, Health Meets Tech. So our first hackathon was in Lagos in 2017. Second one was in Abuja, where I'm based. We've had one in Nairobi, and we also had one in Joburg in 2019, thanks to Dr. Tlaleng. And what we do in all these hackathons is that we are the health organization. In every city where we have this hackathon, we partner with a tech organization in order to deliver it. Again, Health Meets Tech. So that's why the Joburg hackathon was with Impact Hub Joburg. The Nairobi one was with iHub Nairobi. Lagos was Co-Creation Hub Lagos, and Abuja, the Ventures Park. And so we've had 5 hackathons focused on different aspects of health. Interestingly, Joburg Hackathon was on sexual and reproductive health, Abuja, infectious diseases, maternal health, Lagos and Nairobi, general healthcare. And this year, we also have another hackathon, which is going to be virtual. And that hackathon is Pan-African, where we're hoping that we're going to get teams from different African countries that will really come together to begin to find solutions. Because we think that the way Africans would approach the kind of ideas Africans would have for addressing health issues on our continent will differ from people sitting down somewhere in Geneva coming up with a health solution for our people. And that is really why we're so proud of growing this health meets tech hackathon. That's in summary.
Thank you very much. Nana, your ideas of what health should and could look like?
Yes. Well, I think rights-based, like from this discussion that we just had, I think of rights-based digital literacy. So like in reference to what Nomtika has mentioned earlier, on like digital literacy is just a wide spectrum, and it can be starting with like people understanding how to use certain devices and gadgets, to go as far as like understanding that just having a password to lock your phone is not just what privacy means. So I'm thinking of that. I'm also thinking of social protection, strengthening social protection networks. This is something that, especially with COVID and speaking of the internet now as a commodity, people should not pay to get access to information. People should not pay to actually, especially if we are going to stay in our homes for another year. This needs to be a public good. This needs to be something that we don't have to be dropped out just because like we ran out of data. And I think this decentralized services. So like one thing that we can romantically infer of what the internet or digital, and especially in general, meant in the beginning was like basically that the data for users was not something that was centralized. Anyone can access any type of information. I mean, like there is another face to that coin. On the other hand, is like that data is like sucked from users' gadgets is quite decentralized. But like, I mean, on that one side, making this the experience is like for me to access data, to access services, to have the means to be able to make up my mind and take decisions accordingly, should not be regulated by someone who cannot relate to me, to relate to my issues, to relate to my needs and aspirations. I guess it's something that can be, put into the mix when we think about how to move forward. Is like taking all of these into account. And congratulations, Ifani. It sounds really interesting, the hackathon that you're talking about.
Nomtika, before I give you an opportunity, I just want to remind those that are on the webinar with us that if you do have questions for the panelists, thoughts, comments, anything regarding this topic, please do remember to put them in the chat box and we can discuss them. Okay, so Nomtika, over to you.
Right. So for me, this question is really almost like the first one. That right now the answer isn't necessarily universal or at least homogeneous. But I do think that maybe a good place to start, and I know that we challenge the idea of policies and frameworks, and because there's so many of them and they're not being implemented. Ideally, and in a world where these different types of frameworks and policies were being implemented, it would be ideal for, in the case of health or digital health, to have policies and frameworks that hold an intersectional or rights-based or anti-oppressive framework that will ensure that all forms of health infrastructure is available and accessible to all and all who need it. And I think that includes, I think it's very important when Nana keeps bringing up around digital literacy. So it really includes capacity strengthening in our communities. But it also means if we're thinking from that lens, we also think more in depth about what the priorities are. Because no matter how important privacy is and how important digital health is, if you go to a community where they cannot even access water and you tell them about their right to digital privacy, would that really be an issue of priority for them at that time? But at the same time, I like what Dr. T always says. I was saying this a lot at the RightsCon conference in the last few weeks, where she says that I cannot fight for rights I do not know I have. So it's really about being able to think through thoroughly, how do we engage and how do we enter into our communities and to communities we work with, thinking more in depth around what their actual needs are, hearing from them, because solutions come from people that are facing the problem. And I think the examples that Ifeanyi was making around who do we communicate to and how do we communicate that with that person is where design thinking comes in. And I think sometimes we use these big terms and concepts like, design thinking and community engagement and but really all it means is from when you develop policies to when we work on these interventions, the people that we intend to work with to reach or to be through those need to be actively involved from the conception phases of the policies to the implementations of those interventions. Because then if that is the route that we are taking, then everybody ideally has a voice and everybody contributes to the solutions. Because like you said, we're not against technology. We're not against the development and the potential of what technology and tech solutions can bring in health and education across the different sectors. But it is important to really look more in depth around what those interventions look like at the moment and how they can be strengthened in order to be able to meet people's needs, and how the rollout of those interventions and those policies can really be within the priorities of those communities with respect, and really thinking about engaging with then policies in context where there's criminalization and discrimination and a whole lot of stigma around the different issues that we work with and different people that we work with and engage with.
Thank you so much. I mean, that's just a wealth of things to think about. And to hook into one of the points that you made, a question that comes up is, how do we ensure that the issues that we are talking about find expressions in spaces, global spaces, where the decisions are being made? Because that is ultimately, where we need to be focusing our attention in and amongst the other places that need that attention. Is talking about how do we get these issues. Nana was talking about this top-down approach, that dictates to people what they must do. And that the top that's being spoken about there is the place where the decisions are made. So I want to invite Dr. Tlaleng to speak to us about one of those global spaces in which decisions are made, and what we need to do to ensure that these issues get into those spaces.
How are you? Good,
Hi,
good.
Dr. T.
Hi, Nana. Hi, Tika and Ifeanyi. Thank you so much for such an amazing session. And I know that you guys are calling in from all over the world, and it's really just so empowering to reunite with you, all of you, but also just for me to share some of the work that I've been up to. And of course, as the Special Rapporteur on the Right to Health, I'm obviously working on the upcoming General Assembly report, but also in this, strategic priorities that I presented to the Human Rights Council. I was already speaking about the incredible power of digital health, but also reiterating the importance of digital rights and respecting of people's, decision-making processes. And of course, COVID has shown us that, digital health has really an important, and it's an important force, right, to continuation of care, to continuation of information. And as many, and all of you have spoken to the many obstacles that stand between individuals and the enjoyment of sexual and reproductive health rights. And, you've spoken about socioeconomic, class, race, gender, and the important element of artificial intelligence. And I think many of us in the global space are very shy to engage honestly about the fact that artificial intelligence is not neutral and everything is still political. And so I have committed in the upcoming General Assembly report, and thank you to all of the people who responded to the call for contributions. We received more than 66 submissions, including member states, civil society, researchers, academics, who really did, have important insights to share about the impact of COVID-19 on SRHR, but also the possibilities using digital health. And so that report will have a focus on digital health rights. And I hope you can pick it up and use it as you advocate in the different spaces that you work. And I think the key principles for me that shape human rights are non-discrimination, equality, privacy, issues around integrity, autonomy, dignity, and well-being of individuals, and especially in relation to the SRHR, where we live in a global space where we've seen regressions on those rights that we have gained before. And I think the important work now is to protect the rights we already have, but also reimagine a future using intersectional frameworks, being clearly anti-racist, anti-ableist, anti-transphobic, anti-homophobic in the way that we plan and are being truly intentional in how we talk about diversity and inclusivity. So thank you very much. And I've learned a lot today, and I hope that some of your key points will get reflected in that report, and that you can, assist me, reach as many people as I can with the current COVID restrictions. So there's only so much that I can do in the execution of my mandate. But it's really exciting to have all of you here today. And thank you so, so much. And thank you to Jamil for doing such lovely work. Thank you.
Awesome. Thanks.
And that's really what is the vehicle that I believe is going to drive us towards at least, if not all, achieving some of the goals that we set for ourselves. This collaboration. We have got to reach across, the different spaces that we work in to inform and assist each other in creating that sort of multi-dimensional approach to this, because the things that Nomtika is seeing is not necessarily things that Nana is seeing, and realizing that no one context is identical to the other, and that an issue cannot only be approached from one perspective.
Yeah.
So, with that said, if we don't have any questions, I'm assuming that our participants are stunned into absolute silence by the brilliance that has been shared today. And if that is all that we have for today, then I would like to give a really heartfelt thanks to our 3 panelists who have made the time to come and share this information and insight with us. Thank you. Thank you to our panelists for sharing this wealth of information and knowledge in a very, very new sort of landscape towards health equity. And I want to encourage us to continue doing the work, and I also want to encourage us to continue having these conversations. And then just lastly, to remind everyone about the Health Meets Tech Hackathon that is being hosted. Is it August or September?
September 10th to 12th.
Okay. September 10th to 12th.
I just dropped the link on the chat.
Wonderful. There's a link for those that are interested. not only from a professional, but also just from a personal perspective. I think we must absolutely empower ourselves with enough knowledge as we can, because these issues affect all of us, whether we do the work specifically in these fields or whether we are just average citizens. These are important things for us to know. So with that said, I want to encourage everybody to have a wonderful rest of this Friday and weekend ahead. I know that weekends have become such a precious thing of late because we seem to always be working when we're not clocking in and out of work. So thank you everyone for attending. Thank you to our panelists. And until next time, thank you for joining us here at Our Equity.
Thank you.
Thank you so much. This is amazing. Thanks, everyone.
Bye.
Bye.